In stage one, we talked about the whole process of labor, and she went from not dilated, not contracting, through all the contracting, and then to completely dilated. At complete dilation, that's the end of stage one. Now, when she starts pushing, that's stage two. And stage two is from the time of complete dilation through the expulsion of the fetus by uterine and abdominal forces. So the song of the labor and delivery nurse is, should we do open glottis or closed glottis pushing? Closed glottis pushing is what we've been taught for forever. That's what I learned when I first started in OB. We'd tell mom to take a big deep breath, hold it, bear down with all her might, blow that away, take another deep breath, and push, push, push while she's contracting. Well, part of the problem with that is it increases interthoracic pressure. That decreases maternal venous return to the heart, decreases cardiac output, results in maternal hypotension. All of that decreases the uterine blood flow, leading to fetal hypoxia and acidosis. If our kiddo is a healthy kiddo in there, they can recover in between these pushes, but why continue to insult that kiddo when we have found a better way? The better way is open glottis pushing, meaning that she's not holding her breath and bearing down with all her might. It's woman directed. If she feels like grunting while she's pushing, then let her make whatever noises she wants to make, as long as we're talking about healthy noises. Now, if she's screaming a real high-pitched scream, that is not effective. That's telling her body there is something wrong, and like we talked about in the previous section, that's going to release stress hormones, going to decrease the effectiveness of her contractions, and delay this whole thing. So if she's going to make sounds, help her make appropriate sounds. Those appropriate sounds are that grunting. If she needs to make noise while she's pushing, then while she's pushing. Not ee! Think about what you do if you bump your funny bone or you stub your toe. You're going to growl. You're going to grab your elbow and go, oh, that hurt. You don't hit your funny bone and go, ee! So I'm not sure why in labor our women choose to make that E sound instead of that growl sound. Growl sounds can actually help increase serotonin. That's why we do it when we stub our toe or hit our elbows. Let's convince her, if she needs to make noise, to make appropriate noise. Get with her, help her, growl with her to show her what she needs to do. Her labor is much more effective then. All that decreases all those cardiovascular changes. It helps keep our baby well oxygenated, and it allows for a much more gentle delivery of the head, meaning it protects the pelvis. We also have, like we did in first stage labor, our latent descent and transition phases. Latent means immediately after our women get to completely dilated, their body sometimes might go 20 minutes or so without a contraction. It's a physiologic pause. If that doesn't tell us how uniquely designed moms' bodies are for this process, I'm not sure what does. It's almost like her body is going, okay, you've been through a whole lot to get us to 10 centimeters. Now let's take a break, have some chill time before we get into this big stage of pushing this baby out. She may still have some contractions. They're probably going to slow down a little bit just for 10, 20 minutes. Normal physiologic process, but we get panicked and we go, oh no, her contractions slowed down. Let's increase her Pitocin or let's start Pitocin. Her body knows what it's doing. Then that baby gets down to a certain point in that pelvis, and no matter what we tell mom, she has this very strong urge to bear down, and sometimes she can't help but bear down. We call that the Ferguson response. Now she's ready to push, and then transition in our second stage is where that presenting part is on the perineum. We actually see that baby's head or feet or whatever's coming in first. This is a textbook definition. We don't talk about these latent descent and transition in second stage. If she's in second stage, we know she's pushing, and that's what we're focused on. Some of the complications of the lithotomy position, which is that flat on their back, it causes that aortic cavil syndrome, that supine hypotension. And we've spent our entire pregnancy telling her not to be in that position, and here we put her in that position as soon as she becomes complete. It narrows the birth canal just like it did during labor because it does not allow like the tailbone and that posterior spine to move and change position to accommodate the baby coming down through the birth canal. It puts more pressure on the perineum, so there's more trauma to the perineal tissues. If we have mom in the stirrups for a prolonged period of time, or we don't have those adjusted well, that kind of pressure can cause nerve damage and cause vascular accidents, increasing her risk of blood clots because of how we've positioned her in those stirrups. We use this most commonly because it's the most convenient position for our providers. So we know there's a better way. There's a better way to deliver this baby and to protect mom's perineum and to make sure that our baby remains oxygenated. Some of those alternative positions are semi-recumbent instead of flat on her back, not using stirrups. We use stirrups a lot of times because mom can't feel her legs, so she can't hold them and lift them. If we get mom to hold her own legs and pull them up, pull her knees out, even if she can't feel her legs, maybe we have to help move her legs up so she can get a hold of them. But if she can hold them, she tends to bear down much better than if they're up in the stirrups. Side lying. She lifts that upper leg up and out while she's pushing on her hands and knees. This is a little more awkward for the birth attendant, but it's highly effective. It helps change positions if that baby's having trouble navigating. Squatting. Sometimes on our beds, we have a squat bar, and we attach that to the bed so that she can kind of sit and kind of hang on to that squat bar so that she's in an upright position for pushing, and then we can deliver her in that position. They can also squat at the bedside and hang on to the bed. And a lot of our midwives may try this and deliver in this position. And then change positions to help facilitate rotation. If we've had her flat on her back and we're not getting anywhere, there's a reason for that. Those contractions may not be as effective. If we've changed position frequently in labor, why would we stop changing position now that she's trying to have this baby? Move her to her side, move her to her other side, change position while she's pushing to help facilitate this birth. There's a lot that we've learned about how to protect mom's perineum. Used to, we would cut an episiotomy right before delivery, assuming that that little bit of extra space made all the difference in delivering this baby. And we've learned that a lot of our women don't need an episiotomy. They deliver just fine if we're protecting that perineum. What are some of the things we do to protect that perineum? Warm packs. In the past, we also used lubricants and massage of the perineum to help thin it or help relax it. And the reason you see these crossed off is because these should no longer be a routine part of protecting the perineum. Part of this was that if we're not real careful when we're doing this, we actually cause more trauma to the perineum, cause it to swell, and then we end up with more complications. We do see midwives using lubricants and massage, and some of our lubricants, believe it or not, are olive oil. It's highly effective as a lubricant, and it helps massage that perineum out, but we're also not doing it as vigorously as we used to, so we're not causing more damage than what we're trying to prevent. Then that open glottis, short, gentle pushes so that that baby eases out, not explodes out. Not using the lithotomy position, and then control crowning. And so what that means is we have a hand on the perineum to support the perineum as we support the head so that it's a gentle delivery of the head. We've protected the perineum by putting pressure on there. We've protected an explosion, that explosive force of that head, and we've protected the perineum so that she either has minor lacerations or none at all. This is a picture of the baby crowning. This is the baby's head right here. This hand right here is supporting this perineum, gentle pressure on the head so that we have a controlled delivery of the head. Third stage, it begins when baby has delivered and baby is out. That's the start of third stage through the delivery of the placenta. And most of the time that placenta is out in about 15 minutes. And a lot of times our mom doesn't know that she's delivered her placenta. She's so focused on the baby and looking over where they're warming and drying baby, or looking down if we're warming and drying on mom's chest, that she doesn't even realize her placenta has been delivered. If it takes more than an hour, then she's at increased risk of hemorrhage while we're waiting on that placenta to deliver. So we're going to expedite the delivery of that placenta once we hit that 1 hour point. They may draw cord blood, where they actually take the blood out of the umbilical cord and they send that down for a fetal blood type, maybe for some blood gases, maybe for an H&H. The birth attendant is going to examine the placenta for appearance, make sure that it looks like it's intact. Sometimes we can look at that placenta and realize that there are pieces missing, which means it's still on the uterine wall. And that can increase the risk of a postpartum bleed for mom because that uterus can't clamp down like we expect it to. Because that tissue remains in the uterus, it can actually increase the risk of infection. She may end up having to go to the OR in order to have that remaining part of the placenta removed. Some of our hospitals send all placentas to pathology. Other hospitals only send the placenta down to pathology if there's been a problem during this labor and/or delivery. Sometimes our families are very interested in the placenta. There is a thing called placentaphagia, which is where they actually take the placenta home. They can send it off to certain places and have it processed, where they actually dry the placenta and then put it into capsules and send it back to the family, and the family takes that. It's very high in hemoglobin and iron, and so they take that as a way to replenish their body. Some of our families take it home and they feel like if they bury it in the backyard, that prevents the evil eye or harm from coming to that baby. So we have to support if there is a desire for that placenta, and yes, we can send them home with the placenta. After the delivery of that placenta, she is now in fourth stage, and fourth stage is recovery. We do vital signs every 15 minutes for about an hour, depending on what the hospital protocols are. Every time we do her vital signs, we've said this previously, but this is important to note again, we're going to check her fundus, we're going to check her lochia, we're going to do a fundal massage if that is required to tighten that uterus up. We want that fundus firm every time we touch it. We're going to put ice packs to the perineum if it got injured during delivery or if it appears edematous. We always want to make sure that we have some kind of covering on our ice bag. We don't want the ice bag right up against her skin. We can actually put the ice pack, we can put her sanitary napkin on, and then we can put the ice pack on the outside, and that's protecting her perineum while giving her the ice pack. Provide a warm blanket for mom. A lot of times after delivery, they start shaking pretty uncontrollably. I think that's a hormonal release, because if you ask these moms if they're cold, they'll say no and that they don't know why they're shivering. They're typically not cold, but we all like a warm blanket, so it can't hurt her. We are going to continuously observe for signs and symptoms of a hemorrhage. That's why we have to check that fundus and that lochia, that vaginal discharge. We're going to assess the perineum for RETA, that's redness, edema, ecchymosis, drainage, and approximation of edges. You'll learn this in Med-Surg. It applies to our perineal area. We also use our Rita if we're talking about the incision for a cesarean delivery. We're going to promote bonding, initiate breastfeeding. We need to do that in the recovery room. There's no need to wait to do breastfeeding until she gets down to postpartum. The earlier we get baby to breast, the more likely her uterus is to stay clamped down, the more stable our baby becomes, even if they're not breastfeeding, if they're just doing skin-to-skin snuggling. Baby's temperature stabilizes much quicker, their vital signs stabilize much quicker, their oxygen content stabilizes much quicker. That snuggling with the baby actually causes a release of oxytocin from mom's posterior pituitary, so her uterus stays clamped down. We decrease the risk of bleeding. So initiate breastfeeding or at least skin to skin as quickly as possible after delivery to help stabilize mom and baby. We want to assess mom's sensation and strength after the epidural. We have her plant her feet flat on the bed as close to her buttocks as possible, have her lift her bottom off the bed. If she can lift her bottom off the bed and hold it up for about a 10 count, then she has probably enough sensation to safely be able to get up out of bed and ambulate to the bathroom. If she can't get her bottom off the bed, it means she doesn't have full strength and sensation back. It's probably not safe to get her up to the bathroom. Once we get her up to the bathroom, we need to dangle her first so that she doesn't get dizzy and pass out. We need to assist her to the bathroom at least the first time. A lot of our hospitals say we ambulate them at least the first 2 times they're up to the bathroom to ensure that they're stable. We're going to measure the first void. The first void should be at least 100 mLs. And if not, then we are going to continue to monitor for urinary output, because sometimes with our epidurals or sometimes because of the birth trauma, our moms have urinary retention. And if their bladder gets full, it's going to push up the uterus, it's going to prevent the uterus from clamping down, and it's going to increase her risk of a postpartum bleed or a postpartum hemorrhage. During this recovery phase, we're going to teach her perineal care. A lot of times they have a squirt bottle, and so when they go to the bathroom, we tell them to fill the squirt bottle up with warm water, squirt it on their perineum after they're finished, and then pat their bottom dry. Remind them not to wipe, because if they've got sutures or something, wiping is going to be extremely uncomfortable. And so we just need to warn them about that ahead of time. We may do all of this while we're still on labor and delivery before we get her transferred to postpartum. And that's the end of normal labor and delivery.